One of the topics in Dopamine Nation that I found most fascinating was the degree of pain that people report and how it varies from country to country. So maybe you could talk a little bit about some of the research behind this sort of surprising phenomenon.
Yeah, so I'm not remembering now the exact statistics that I quoted in the book, but broadly, what is a very interesting phenomenon is when you look at either psychological or physical pain surveys, where you give a bunch of questionnaires worded in sensitive ways to account for differences in values or subcultures, etc. What you find is that people living in the United States are among the least happy people in the world, the most depressed and anxious people in the world, and the people experiencing the most physical pain in the world. And this is a surprise, right? Because we have more access to mental health care treatment than anywhere in the world. We consume some 80% of the world's hydrocodone, a highly potent opioid, even though we constitute 5% of the world's population. Now, we could go down that road about how opioid essentially, supports the argument in Dopamine Nation that repeated use of a highly reinforcing substance or behavior causes more pain, because that's what opioids do if taken habitually over time for pain. But the larger, message here is that we're clearly getting something horribly wrong about how to have a flourishing existence in the modern world, as well as how to treat psychological and mental suffering. Because there is a dominant mode in psychiatry and psychology today that says if you are feeling any kind of pain, you should immediately make yourself even more comfortable and remove pain from your life, make yourself more comfortable. And yet our best attempts to do that are not leading where we want to go. So, for example, even just global happiness surveys from prior to the year 2000, what we saw was that as countries got wealthier, this is prior to 2000, as countries got wealthier around the world, people seemed to get happier. Gee, that makes a lot of sense, right? Nobody wants to live in poverty. But for about the last 20 years, it's been some kind of tipping point, and the wealthier the country, the less happy people are, the more anxious, the more depressed, and the more in physical pain.
Well, I just pulled up that statistic because I think, it's very interesting. It's worth reading that. Okay. 34% of Americans said they felt pain often or very often, compared to 19% of people living in China, 18% of people living in Japan, 13% of people living in Switzerland, and 11% of people living in South Africa. So the question is, why, in a time of unprecedented wealth, freedom, technological progress, and medical advancement, do we appear to be unhappier and in more pain than ever? Which you pointed to, but I think that is just a very fascinating study and statistic.
Yeah, and it really begs the question, right? Like, what is going on? And so the hypothesis is that it is the excess of highly reinforcing substances and behaviors that we were not evolved for that's actually leading to a kind of chronic dopamine deficit state.
Right. I think this is an interesting term and worth bringing in, but you talk in the book about, briefly, something called opioid-induced hyperalgesia.
Hyperalgesia, yeah.
Algesia, okay. Yeah. And I have so many aches, and I wonder if it's connected to algesia, but more generally, just dopamine induced because I'm not. I don't take opioids, so. But I think that's the general hypothesis.
Right. So the idea in giving opioids liberally for pain, which started at the end of the 1990s in response to a huge promotional campaign by Purdue and others, was to alleviate the rising rates of pain in an aging population or people living with chronic pain conditions. But instead, what happened is that people seemed to, over time, experience more and more pain. And now we see many otherwise healthy young people coming in with pain all over their bodies for no identifiable reason. And so again, it's hard to know exactly what is going on, but the hypothesis is that it's actually the ways in which we are insulated from pain, detached from our bodies, not moving our bodies in the way that they were meant to be moved, not connecting brain and body, so that we've got this busy brain trying to figure out what the body is doing. The body is sitting there all day, not doing anything. And then a brain that gets really confused by that and reads all kinds of sensory signals as pain signals.
Mm-hmm. And then there's also this, I mean, you have these diagrams in your book with like pain gremlins. I don't know, maybe I think they're gremlins, not goblins, but there's it's called a seesaw, right? I was going to call it a teeter-totter,
Yeah,
but
no, that's good. Either one. Yep.
I think it's called a seesaw. But there's a mechanism in our brain that contributes toward this tilt toward the pain side of the seesaw after we have a flood of dopamine. And maybe, I mean, we started off with a little bit of neuroscience, but what is the mechanism that contributes to this tottering of the seesaw?
Right. So this is called the opponent process theory, and it's based on a lot of information and science in the past 50 to 75 years showing that pain and pleasure are co-located in the brain. So the same parts of the brain that process pleasure also process pain, and they work like opposite sides of this balance. So imagine that when the balance is at rest, it's level with the ground. That represents our pleasure pain reward system when it's at rest, or what neuroscientists call homeostasis. When we experience pleasure, it tips one way. When we experience pain, it tips the opposite. And there are certain rules governing the balance. And the first is that the balance wants to stay level, and our brains will work very hard to restore a level balance with any deviation from neutrality. And the way that our brains do that is first by tilting an equal and opposite amount to whatever the initial stimulus is. So when we use an intoxicant, releases dopamine in the reward pathway, the balance tilts to the side of pleasure. But then these gremlins, which represent neuroadaptation, hop on the pain side to bring it level again. They like it there, so they stay on until it's tilted an equal and opposite amount to the side of pain. That's the come down, the after effect, that moment of wanting to read one more chapter in my romance novel. But if I wait long enough, and if I'm not yet addicted, gremlins hop off and homeostasis is restored. But the second rule of the balance is that with repeated exposure to the same or similar highly reinforcing stimulus, that initial deviation to pleasure gets weaker and shorter, and that after effect to pain gets stronger and longer until essentially those gremlins multiply. Now they fill up this whole room. They're camped out on the pain side of the balance. And now we're in a chronic dopamine deficit state, which essentially just means we've changed our hedonic or joy set point. Now we need to do that behavior, not to feel good and get high, but just level the balance. And when we're not using, we're walking around with the balance tilted to the side of pain. And to me, that's a really helpful metaphor for understanding what happens in the brain as we get addicted, why people with severe addiction will relapse, even after they can see that their lives are so much better when they're not using it. It's because those gremlins don't get off right away, right? So if we've been using that substance or behavior for weeks to months to years, it may take weeks to months to years for the brain to really fully heal. And in some cases, the plasticity to do so may be lost, which means that now you've got kind of a permanent dopamine deficit state. So it's a way to sort of understand that whole process and how it gets broken by a world in which dopamine is released so much and so quickly in response to these manufactured kind of stimulants of all sorts that our brain, really can get permanently damaged from the experience.
I find this story so compelling, just also because it meshes with my own experience. But to recapitulate, to make sure that I'm totally on the same page, and my listeners are as well. So the neuroadaptation, or the process of neuroadaptation described by the opponent process theory, that is figuratively embodied by your pain gremlins, it results in when the seesaw goes way up because you're very happy with your flood of dopamine. After that, the pain gremlins jump on, it goes all the way down, and they pile on until eventually you're in this perpetually negative state. And then when you don't have your drug of choice, which at this point is just getting you to a state of equilibrium, that's when you feel at your worst, because there's nothing to counterbalance the pain gremlin. So for me, I mean, when I was like at my worst binge eating, if I would stop doing that, that's when I would feel at my absolute worst. And it's because nothing is fighting off those pain gremlins.
Exactly. You said it beautifully. And so when people get into recovery, what I explained to them is now you're going to be taking that weight off the pleasure side. But those gremlins that you've accumulated on the pain side, they're going to slam you down to the side of pain. You're going to experience the universal symptoms of withdrawal from any addictive substance or behavior, which are anxiety, irritability, insomnia, depression, and craving. And that typically goes on for 10 to 14 days in terms of the acute withdrawal before it starts to abate, before the gremlins get the memo, oh, wait a minute, we're not getting this exogenous source of dopamine, time to hop off the balance, and for homeostasis or healthy dopamine levels to be restored.
I'm right now, it's occurring to me that you had a patient who was, I think, a high schooler and addicted to cannabis, and you said to her that you wanted her to stop smoking for a month because that was the minimal sort of safe duration to reset the seesaw. I'm wondering if you ever encounter patients who have a particularly intractable addiction where their brain just doesn't want to go back to normal. And if that is the case, how you deal with that. Perhaps this is where some of the pharmaceuticals enter.
Yeah, so we do see that all the time, right? Because the people who have that level of addiction will be the people who either come to us for help, relative brings them in, or they have severe consequence professionally or with the law, so that kind of mandates them coming in. And what we find is that even in those individuals, if they are able to abstain from their drug of choice for 4 weeks, the majority of them will start to feel substantially better. Of course, they're not going to be all the way healed and their addiction isn't cured because we think of it as a chronic relapsing and remitting disease. One way to imagine that is that these gremlins, once created, they may hop off, but they don't entirely disappear. They're waiting in the wings, eager to hop on again. And there's no buildup period, right? Now you don't have to multiply the gremlins. They already exist and they hop on. And we see that clinically. We see that also with imaging. When my colleagues looking at how recovery happens in the brain and noting that there are permanently damaged areas. So the way that we have to deal with that is often by higher level of care. So having people go to a residential treatment facility, for example, where they don't have access to their drug, can be a lifesaver, for many people. I mean, there's so many jokes and denigration of rehab, but I can tell you as an addiction treatment psychiatrist, I'm very grateful for residential treatment because some people just literally cannot stop on their own. We have medicines that we can use. The classic example is opioid agonist therapy, which is to say using an opioid like methadone or buprenorphine to treat an opioid addiction. And it seems very counterintuitive, but what we think, again, going back to this metaphor, is that sometimes even prolonged abstinence will not, in some people's brains, get those gremlins to hop off, which means that, people are constantly using up all their energy managing cravings. And so they really can't move forward in their lives. But if we give them a long-acting opioid like methadone or buprenorphine, it allows them to restore homeostasis so that they can engage in other aspects of their life and in their recovery. And there are other medicines that we use to help with that. There's also, very commonly spiritual pathways. So a lot of people in recovery get there, especially the most severely addicted, through spiritual pathways, often through the 12 steps, this notion of higher power. Of course, we don't know exactly how that works, but we know phenomenologically that it can be very helpful, maybe by activating other parts of the brain that allow people to modulate these reward circuits. Or maybe it's some other type of intervention. Who knows?
Well, just to put a bow on this aspect of our conversation, I am wondering then, so you brought up at the beginning this biopsychosocial model of addiction. So obviously there are going to be social factors that contribute to relapse, but psychologically, biologically, I'm guessing that the way that we can understand the tendency to relapse is through this picture of the seesaw. The withdrawal symptoms just become so unbearable to the addict that in order to get back to equilibrium, they have to return to their substance.
Yeah, I think there are sort of three ways to think about the biological mechanisms. One of them is the one you identified, the way that exposure itself to a highly reinforcing drug or behavior changes our brain over time. That gets us caught on this hedonic treadmill or addiction vortex. The other way is the inborn or innate inherited vulnerability to addiction. So we don't all come into this world with equal amounts of vulnerability. There are some people who really are much more vulnerable to the problem of appetitive control than others. And those individuals will struggle with addictions to all kinds of things. They will get into recovery from one addiction only to find that it transitions to another addiction. Those are the most severely addicted among us, for whom this modern ecosystem is incredibly challenging. I talk about them as modern day prophets for the rest of us, because as a matter of survival, people with recovery from severe addictions have had to figure out how to navigate this world. I also hypothesize that, in whatever thousands, millions of years ago, even probably just hundreds of years ago, people with the inherited addiction vulnerability were probably the most valuable members of a tribe, because they were willing to work harder, walk further, to get, find the berry bush or get water or find a mate. So what was once very advantageous and therefore conserved through evolution is now a bit of a liability. But if you can channel it in the right way, people in recovery from severe addictions turn out to be some of the most amazing people you will ever meet. So it can still be a positive, and not necessarily a negative. And then the third way is some sort of, other co-occurring factor that's not like an addiction vulnerability, but another co-occurring factor that contributes to addiction or vulnerability. And that's things like co-occurring mental illness. So we know that people with co-occurring anxiety, bipolar disorder, depression, schizophrenia, they have rates of addiction that are much higher than the general population. And that's probably because they're turning to these behaviors as a way to manage their psychiatric symptoms. Some of them will realize quickly that it doesn't work. The more you use a substance or behavior in an addictive way, the worse the outcome of your mental illness. But nonetheless, it's a doorway that gets people into using the substance, which for some people then leads to a co-occurring addiction.